Hello, everyone. This is the AMOGS Global Webinar. We are starting yet another series. I'm Dr. Suyash Naval, and being AMOGS Endoscopy Committee Chairperson, I invite you for a new webinar on ablation therapy in gynecology. Dear friends, as you all are aware, that recently Honorable Supreme Court has pointed out and has advised all the states and union territories to create a strict monitoring and guidelines for all the hysterectomies in under less than 40 years of age. More so, even when we talk about uterine diseases like fibroids and adenomyosis, we are always thinking about what alternatives can we have for the medical management and for the surgical management. And probably ablation techniques, which are well-known techniques, which were introduced about 20 years back. But right now, there is a lot of development in instrumentation and technology, and ablation techniques have improved and have become very precise. This could be an alternative to save more uteruses. So before going in for the main topic, and as we have Dr. Xiaoming Gong, who has extensive experience in ablation. He has been working on this technique since 7 years and performs at least 7 to 10 ablations per month. So before moving to his lecture, let me introduce the Honorable President of AMOGS, Dr. Rajendrasingh Pardeshi. He needs no introduction. He has been active member of AMOGS since a very, very long time and has been a faculty in FIGO and all the national and international conferences, has several papers. He absolutely needs no introduction. We also have Dr. Sujata Dalvi. Madam is the secretary of the AMOGS, and she is also clinical secretary of Mumbai Obstetrics Gynec Society and honorable clinical associate at Navroji Wadia Maternity Hospital. And we have guest of honor, Dr. Sunita Tandulwadkar, madam. I am very happy that she has joined because she also has a large body of work on fibroids and all complex cases. We always keep watching her videos. And ma'am is the state coordinator for the AMOGS. And also, ma'am, I wish you well for the upcoming FOXY elections. Before we start, I would request Rajendrasingh Pardeshi sir to speak a few words about this webinar.
Good evening, everybody. Respected guest of honor, Dr. Sunita Tandulwadkar, Dr. Sujata Dalvi, our secretary of AMOGS, and our guest speaker, Dr. Xiaoming Gong. First, I wish to congratulate you for organizing an academic practical webinar on ablation technique and therapy in gynecology. Preserving uterus and appendages before the age of 40 is really a challenging task due to its relation to the hormonal disturbances, psychological consequences, osteoporosis, increased cardio risk, and so many side effects. And with the conservative treatment with medicines, ablation is really gold standard procedure to overcome this. And Dr. Xiaoming Gong and Dr. Suyash will be the right persons today to enlighten us the ablation therapy in gynecology. With the able chairpersons like Soumil Trivedi and Sanket Pisat, this will be an interactive session. Dr. Sunita Tandulwadkar will highlight one point of our guest of honor and our AMOGS state coordinator. Herself, she is an expert laparoscopist, and I am fan of her uterus-saving surgeries, especially in difficult myomas. I've seen her surgeries, and she is expertise in that. I wish every success to Dr. Sunita Tandulwadkar for her future endeavor in FOXY. I know you are waiting for Xiaoming sir's deliberation on ablation therapy. Wishing every success to this webinar. Enjoy this academic feast. Thank you. Thank you so much. Thank you so much.
Thank you so much. Thank you so much, sir, for your words. Dr. Sunita, ma'am, can you shortly speak about the topic and your thoughts?
Thank you so much, AMOGS, for giving me an opportunity President Dr. Pardeshi sir, the way you are working with all the chairperson, I think AMOGS is the rocking state in our entire India. Every chairperson of your different committees are working to their best. Suyash, your love, your passion for whichever subject you take in, I absolutely adore. You really have given, and what you call that vaginal approach to laparoscopy,
V
single
notes.
port V notes. Amazing, yeah. You are persistent with this. And thermal ablation, it's a nice thing. I'm going to listen to as it is. I'm traveling because it will be wonderful, Dr. Gong, to listen. Way back 20 years ago, this thermal balloon which had come by Johnson and Johnson, I was the one who bought this machine. I have done n number of thermal ablation and I used to be very happy. Maybe initial 2-3 months, I used to keep these patients on Sevistar once a week for 3 months. And this thermal ablation have taken a huge work. Of course, TCRE, many of us are doing for last 3 decades, 2.5 decades, I should say. But in TCRE, what the problem used to happen is, if you have not done the cornus very well, the rest of the cavity get obstructed, you will have a hematometra and an agonizing pain and dysmenorrhea for the patient. So you really need an expert to deliver the TCRE, while these balloon technologies, which is just the passing of a thermal heat, the machine does. The surgeon doesn't play important role in that other than just passing the balloon, inflating and making the machine on. So I felt when today we are talking about save the uterus, Marina has helped us in not getting into vaginal hysterectomies for the DUB patient, simple because of the hormonal imbalance. Naturally, thermal ablation will be one of the non-invasive technology where patient can be, because we know there are so many advantages and disadvantages of all the conservative technology. So it will be wonderful to see what Dr. Gong has to say with his series of work. How, of course, he's doing so much work. You said 10 cases per month. It means he must be happy with his results, and that's why he is working with that. So I'm looking forward to, and thank you for having me in your webinar, Suyash.
Thank you so much, ma'am. Thank you. I'll quickly introduce the chairpersons for this webinar. I'm glad to have Dr. Sanket Pisat. He is a consultant endoscopic surgeon at several respected hospitals in Mumbai, and we all know him for his wonderful innovations like Dr. Pisat's VVIN needle and for injecting vasopressin and shoelace knot. And of course, he makes us all of us proud. And we also have Dr. Soumil Trivedi. Dr. Soumil Trivedi has works in Trivedi Hospital in Mumbai, which everyone knows about. And of course, he has a large body of work on fibroids and works extensively on in-bag morcellation and is conducting active research in that. Also, he is the youngest managing committee member of IAGE. So if I can request Dr. Soumil, without wasting any time, if you can introduce Dr. Xiaoming Gong.
Thank you, Suyash. Thank you, the AMOGS. Thank you, Dr. Pardeshi, Sunita madam, for having me here. It gives me immense pleasure to invite Dr. Xiaoming Gong, who is the co-founder of the WOI OBGYN medical group in China. He's the head of Uterine Fibroid Non-Invasive Treatment Center in the WOI group, chair of China Medical Group Association. And his medical education from 1990 to currently is very vast, very elaborate, right from the medical early medicine to residency and to the current status wherein he is the founder of 12 non-invasive and minimally invasive uterine fibroid treatment centers in China spread across the entire country. And his special interest is non-invasive and minimally invasive therapy for fibroids and adenomyosis. He's the CEO and founder of the largest OBGYN professional website in China, www.obgyn.cn, and the chair of the Chinese Medical Group, 2018 to 2019. I welcome you, sir, and we are all eagerly waiting to listen to your deliberation.
Okay, thank you. Thank you for Dr. Sovia to invite me Can you hear me well?
Yeah. We can hear you. You can go ahead with your presentation, Dr. Gong.
Okay. Okay. So let me introduce myself. I do gynecology most of the time, but since year 2009, I started to do the ablation therapy. We started with HIFU. So actually, I do endoscopy surgery and ablation therapy as well. So my experience from the in the ablation therapy, we started in 2009. So it's about 14 years. So right now, I worked in the multiple cities in China, and we do endoscopy surgery and also do the ablation therapy. So we do both. So till now, I think that everybody knows that the endoscopy surgery is we call it a minimal invasive surgery. But right now, for uterine fibroids and adenomyosis, we have many other choices. Like we have UAE, we have HIFU and microwave and the radio frequency. So these three methods we also call ablation therapy. So right now we call these three methods and combined with UAE, we also call them super micro-invasive therapies. So it's different with traditional endoscopic minimally invasive treatment. For the traditional resection surgery for the uterine diseases, we do the hysterectomy. Also, we do mammectomy. We do it with laparotomy, laparoscopic surgery, or with vaginal surgery. But with ablation therapy, it's totally different. We use the energy we produced by the focused ultrasound or microwave or radio frequency to destroy the local lesion. So the idea is not to resect it. We do the ablation. We do to try to destroy. When the temperature rises to over 69 degrees, the tissue will degenerate in 1 second. So ablation therapy right now is widely used in stromal tumors like liver cancer, kidney cancer, lung cancer in China. So in China, we have a separate department in many hospitals. We call it minimal invasive tumor center in many departments in the tumor department. So oncology department. So we have many oncologists to do this ablation therapy. We started with HIFU, and later on we use microwave. So microwave is also right now is our main method for the ablation therapy. So let's start with HIFU. First of all, I also want to emphasize on the advantage and the disadvantage of the HIFU, of the ablation therapy. For ablation therapy, it has many advantages. Like this has a fast recovery, there's a minimal pain, no wound or very tiny wound with no or minimal blood loss. And it also has the disadvantages. Like first of all, if we do with the HIFU and the MR guide HIFU, you don't have the pathology. And compared with the resection, traditional resection method, it has a higher residue tumor. It also has a higher infection rate. Compared with the traditional surgery, it has higher recurrence rate and reintervention rate. So it also, we have to admit, this method has the advantage, also it has disadvantages. Let me skip some slides. So let me introduce the pre-treatment evaluation. So for everybody who want to do the ablation therapy, MR is very necessary. For the MR signal, we want to check especially the T2 signal. We want to see if the T2 signal is dark. So dark means that it has less water inside the myoma. So it is very easy to do the ablation. If this one is higher signal, That means with a much higher water inside the tumor, so it makes it very hard to do the ablation therapy. We also want to do the MI to rule out the malignancy, and then we also want to check if it is very safe to do the ablation therapy. And if we want to do the HIFU, we have to know if the lesion is not if it is too far away from the skin. If this lesion is about 14 centimeters far away from the skin, it is not unable to treat with MR guided HIFU. These are many situations we cannot do that with the HIFU. So this the second picture is that this picture would mean that this is a T2 high signal, which means that it is relatively not easy to treat with energy. The first patient is this one. Is a patient is with adenomyosis, but is this one? She has a ball in front of the uterus. With this situation, we cannot do the ablation therapy with HIFU because HIFU have to penetrate the skin, the ball, and will reach to the lesion. So the ball cannot stop the ultrasound wave. For the third patient, this one patient, she want to have the fertility requirement. If we do the ablation therapy, it will destroy the endometrium as well. So this patient is not suitable for the ablation therapy. We would like to do with hysteroscopic surgery. So the first technique we want to introduce is HIFU. HIFU works similar to the solar cooker. So the ultrasound wave will come together to the target area, and the temperature of the tissue, if it's reached to 70 degrees, and will be destroyed in 1 minute. So this is a lesion in liver. We do on the liver tissue. We can see the ultrasound wave come together into this area and cause damage to the tissue. This is our HIFU machine, which is produced from a Chongqing company in China. We call it JC200. Let me see to share with the full screen. So this is HIFU. With this machine, we can see the energy is coming from this prop and it come together into the skin, into your body, and it will penetrate your skin. So it is a no scar surgery. For the indication for HIFU, usually we treat with lesion if the anterior wall lesion should be greater than 2 centimeters. For the posterior wall, the myoma size should be, or the adenomyosis size should be greater than 4 centimeters. If it's too small, we cannot focus the ultrasound wave very good. So this one for our adenomyosis and uterine fibroids lesion, we have to select the correct patients. And if the lesion is greater than 10 centimeters, usually it would take a longer time. So we would prefer to do with gynecology treatment before the treatment, and after the gynecology treatment, it will make it smaller and relatively easier to do the ablation therapy. Contraindication like the malignancy and infection disease, we cannot be treated. We will wait sometimes. For the malignancy, we would like to do the hysterectomy instead. If the MI signal is not too good, we will prefer to do the hysterectomy. But for some patients, I will mention about the biopsy instead in minutes. Complications, we have to be aware of these is HIFU complication, including the skin injury, bowel injury, and bladder injury. The very special one is a nerve injury. Nerve injury is because if the ultrasound wave will go from the skin into your body, and if it reach to the lesion, and it will go beyond the lesion. So if the energy is go too far beyond the lesion, it will cause the nerve damage. So this is unique for the HIFU. Also, we have some cases of the uterine rupture because if you injury is the anterior wall or posterior wall, it will cause the uterine rupture in the pregnancy. For the symptom relief, let's see the result. This is the many studies from the journal. We can see after the treatment, the patient's the lesion size will decrease in size. Usually in 6 months, the myoma will decrease about 60%. And for the symptoms, it will relieve in the majority of the patient after 6 months. This is a multiple center study in China. We have 2,400 cases in China in 11 centers. So compared with the surgery, you can see HIFU has less bleeding, less fever, and also other less infection and less DVT, the less bladder injury. Compared with the hospitalization day and the recovery day, you can see HIFU compared with hysterectomy or myomectomy has a faster recovery time. But I think this study is conducted by the HIFU company. So I think we have to be aware of the complication, because in this serious study, they didn't mention about like the bowel injury rate. So I just need to mention about the complication. You have to be aware of like the bowel injury. The rate is about in 1 to 3 in 1,000 cases. So you have to be aware of the complications. So this is my study for the adenomyosis patients. We did the HIFU for the adenomyosis patient. You can see many of the patients' VS score decreasing in majority of the patient, but one cases she had a hysterectomy because of no pain relieved. This is our VS score. In mean, it will decrease to about 3.7 in 3 months. This is a case of our adenomyosis patient. This is a before treatment, and after the treatment, you can see the anterior wall will shrink in size. And this is the case we did the hysterectomy after the HIFU treatment. I just want to show this case, this picture. You want to see why the patient she had a failure, or she had a symptom persisted, because you can see this lesion, this area is a lesion we treated with HIFU, but we can see, but this area is not treated well. So patient, she didn't have a very good symptom relief. So that's what cause the recurrence, or we call the second surgery after the treatment. So I just want to show with this picture, want to see what will happen after the ablation therapy. So this will cause the necrosis after the therapy. So this area cannot be detected with ultrasound, but we can be detected with enhanced MRI. So if they, I think because most gynecologists, they don't know about ablation therapy, they will just use the ultrasound or MRI to detect the fibroids and the adenomyosis. So for us, we focused on their symptom. So if we want to see if you found this fibroids, is what we call the recurrence, that will be about 100% of the recurrence. So I prefer to use the symptom, the score, how bad you symptom after your treatment. It's got relieved. So in my cases, our second surgery rate is about 15% for HIFU in 2 years. The second technique is also is HIFU, but it's MI guided focused ultrasound. We use this technique since year 2013. So it's about 11 years. We also is our first gynecology team in China. I think maybe we are probably the only gynecology team in the world to do the MI guide focused ultrasound, because in the world, most most hospitals, they do the with radiologists to do the MI guide focused ultrasound. For the MI guide focused ultrasound, the advantage of this technique is we have a very clear image. So with the MI image, we can do the treatment very easily. I want to show this picture. So you can see with the MI image, we can divide the fibers into many pieces. This is divided by computer. So what you need to do is you just outline the boundary of the lesion, and we marker the skin and the border of the uterus. So the computer will help you to calculate this area. One advantage of the MR guide focused ultrasound is the temperature monitor. So you can see this blue area is the target area. In this area, in this window, you can see the temperature, the simultaneous temperature of the point, the monitor. So the advantage of the MI guide focused ultrasound is the safety. So we can see which area is ablated, which area is not ablated. So this, I think, that because we do many of the HIFU with the ultrasound guides, we compared with the MI guide focused ultrasound. This is the advantage. But the disadvantage is that it takes a longer time. So like if we do the MR guide focused ultrasound, usually we can just do 2 to 3 cases in one day, but we can do 4 to 6 cases with HIFU in one day. The disadvantage, the advantage of the focused ultrasound is also this patient. She is 10 minutes after the treatment, so you can see this is the good thing for the focused ultrasound. Has a faster recovery and no scar and no bleeding. But disadvantage, I have to say, compared to HIFU, it has taken a longer time, and compared to traditional surgery, HIFU will have a higher recurrence and the reoperation rate. This is our study for the adenomyosis. So the volume of the uterine volume is decreased. VIS cones is also decreased. This is a very good picture to let you see the myoma ablation after the treatment, how it will decrease in size. This is before treatment. This myoma is about 10 centimeter. So after 3 months, this myoma shrinks to 9 centimeter. So after 1 year, she is shrunk to 8 centimeter. I think we did another ultrasound for her after 3 years. The fiber shrunk to 6 centimeter. So this dark area, we call it NPV area, non-perfusion volume. This area will decrease in volume, in size after the treatment. But if you can see this area, we can see a very tiny area. In this area is a residual area. So this residual myoma will gradually grow up after the treatment. So just want to know how it will be looks like after the treatment. Same thing, I'll skip this one. Pregnancy is also safe. This is a study in US. FDA approval is using for the pregnancy woman because it has not too many other complications during the pregnancy with the normal group. This is our case for the MR focused ultrasound. So After the treatment, you can see the endometrium is kept well, and also the myometrium is kept well. This area, dark area, is ablated. So the myoma has some very little lesion is left in this area. She had a cesarean after the treatment. This is a very interesting case for the adenomyosis case. We just had this case in. We had a discussion in this for this patients last month because this patient she had a adenomyosis for 7 years, and she had a recurrent IVF failure, and she had a miscarriage in 2018. And she also has open surgery in 2018. And after the surgery, she did another IVF, also had a failure. So when she started to another IVF, she found that the posterior wall is thickened again. So she wanted to do another IVF cycle. So we did ablation therapy. We did use microwave. So after the treatment, she get to have a GYN for 4 months and IVF success. And finally, she had a cesarean section at 33 weeks. The third technique we use is microwave. Microwave just works as well as your microwave oven in your home. So we use antenna to insert into the lesion. Let's see this video. So we insert this needle into the lesion area. Compared to with the HIFU, it has faster, works faster. So you can see this area getting white, ablated. With the time accumulating, the lesion becomes bigger and bigger. So with the microwave, we did with the ultrasound guide. We usually will puncture the needle anteriorly from the abdominal wall, and we place the needle inside the myoma or inside the lesion, and we ablate the lesion little by little. So it works similar like the HIFU, but it's directly inside the lesion. Indication and country indication, I will skip to this one. So this is the circulation water. It will cooling down the needle. So this needle is guided by the ultrasound, and we insert the needle. This is the microwave needle. And with the ultrasound guide, we will puncture the needle. Let's see, this is a myoma ultrasound image. So, so usually in the past we do the enhanced ultrasound first. We check the blood supply inside the myoma. So with the ultrasound guide, we insert this needle inside the lesion, and then we just start ablation. And little by little, we'll ablate this lesion. With the detection of this this white area, we know this area is ablated. So if you started with HIFU, you'll be very happy because it will work very, very faster with compared with HIFU. So right now we can do 8 cases in 1 day with microwave, but in the past we can only do like 4 to 6 cases with HIFU. We can do 2 cases with MR guide focused ultrasound. So that's why we choose I think the most gynecologists are very. I think they want to work with a faster tool. This is the treatment. You can see, you can hardly find this hole, a tiny hole, a tiny wound on her skin. So this one we also call it super microwave surgery. So let me skip this one. This is our two cases.
这是一个子宫肌瘤患者做了。
So this is the two uterine fibroids. She had a pregnancy requirement, so we ablated these two fibroids. I think that the ablation time in total is about 20 minutes, so it's a very short time. What faster. The last one I want to mention is about the radio frequency. So in China, we have one company, we call it it's a BBT system. So BBT system is a reusable system prop. So with this prop, we can insert this prop into the myoma or the adenomyosis lesion. With this prop, usually we do transvaginally. So with the detection of the so this, you can see we can insert this prop with the ultrasound guide, abdominal ultrasound guide. We can insert this prop into the myoma, and then we destroy the myoma region. The only thing compared with microwave, it has low efficiency. It works relatively slow. That's the ultrasound image. That's just the trick how we do the ultrasound with treat with adenomyosis. So this works very similar with like the microwave. Usually, if the lesion is greater than 5 centimeters, we cannot treat with radio frequency probe. This reusable BBT system. So I just want to mention the advantage of this BBT system. It also has a probe for endometrium. So patient who has heavy bleeding, and we can destroy the endometrium as well with this probe. I want to skip this one. And finally, I want to mention about the complication. In the the session, I mentioned about this kind of the complication, especially the organ injury is the most dangerous one for us. This is microwave caused damage in the beginning because we don't have the experience. Once we found that the circulating water is not working well, so it causes a burn with the skin. This is unique for the HIFU. It's called the nerve damage because of the energy go beyond to the lesion, that causes the bone, the nerve damage in front of the bone. This is a uterine rupture case report. Why she had a uterine rupture? Because the energy go beyond the lesion and damages the uterine wall. So I just want to mention to most of the gynecologists that ablation therapy is just like a knife, like your endoscopy knife. How you use it is how safe it is. This I want to share one case is about. She is a very traditional myoma patient, and she had multiple fibroids, and the uterine size is very large. And we treated with the IAGE first, and we did ablation, and we did ablation therapy, and we also do the hysteroscopic surgery to resect this type 0 myoma, and we ablate this type 3 to type 5 myoma with microwave. So that's the image after the surgery. You can see the whole dark area is damaged to the uterine wall. So this is the MRI image after the treatment. This patient, she had a fever after the treatment. 2 weeks later, she got a very high fever, and we had antibiotics for her for 1 week, but she still have high fever. Finally, we did a DMC for her, and after that, she recovered well. So I just want to mention you for the ablation therapy, it has a higher infection rate compared with traditional resection surgery like the laparoscopic surgery or endoscopy and the hysteroscopy surgery. So this case, I just want to show and want to remind you that if you want to do more and more cases, you will see many cases of the infection. The last one I want to mention is we call this technique we use for ablation therapy for adenomyosis only, because we found some cases with the adenomyosis patient. When we do the ablation with the percutaneous ablation, usually we have to leave a 5 millimeter to 1 centimeter thickness of the uterine wall. So for this patient, she will have persist pain. So we did some cases. We did some laparoscopic assisted microwave ablation because we want to have a higher ablation rate compared with percutaneous ablation therapy. So we did many cases for the adenomyosis patients. Right now, I think we have about over 40 cases, and we found that compared to the percutaneous one, ablation, it has a higher MPV rate and a higher pain relief rate compared to that one. So you can also manage ovarian lesion with endoscopic surgery. So I think I will finish my topic today. So in the last, I just want to mention that in China, we have an old saying we called, if you are a warrior, you have to mention, you have to master 18 weapons as just everything, you have to use it well. So I think that for the ablation therapy, it's not just a new way. It's just because in China we have many doctors. They are from the ultrasound department. That's a very unique thing, I think, in the world. We had a ultrasound department. They just do the ultrasound for the examination and do the ultrasound guided treatment. Well, only they don't do the laparoscopic and open surgery. But I think that for the gynecologist, we have to master every tool. We have to do open surgery. We have to do laparoscopic surgery. I do also do many vaginal surgery as well. I post my vaginal mammectomy and vaginal hysterectomy on my YouTube channel. If you have interest, you have also good to have a look. But I also want to let you all the gynecologists, we have to master the ablation therapy. It's a very good news. From my point of view, it's a new generation of the surgery options. It's a totally new. I think everyone have to learn about it because it will give you patients a new way to treat their diseases and to keep their uterus. Many women in China, they don't want to remove the uterus. Even you tell them that remove uterus is not, it's a good thing. It can also decrease the oncology rate, the tumor rate in the future, but they still want to keep their uterus. So I think everybody have to learn how to do it. So that's my topic today. So I finished my talk. This is a trend. This gray curve means that our ablation rate increased in the recent years. So sorry, I think that I took too long time. I finished my talk.
No, I think it's perfectly in the right time considering when we started. Thank you, Dr. Xiaoming, for that elaborate review of various ablation techniques. Suyash, do we take the questions right now or after the second talk?
After my talk, we'll take the questions. I have a very short talk. I'll just show a couple of videos which we have done. And thank you, Dr. Xiaoming. I think your last slide said it all. Like, knowing 18 weapons, how to use them. I think today's gynecologists cannot just rely on one or two techniques. We have to be more versatile and try to master many things. So I will quickly share my screen, and I do not have a great expertise in ablation like Dr. Gong here, but we started in 2021, and I hope my screen is visible.
Yes, Suyash, yes.
Okay, this thing is not responding. So we started in 2021, and we might have done about 24 cases up till now. And my selection is, I try to be very, very careful and try to take only moderate size lesions. And I especially focus on microwave ablation because I think for a gynecologist, as rightly said by Dr. Gong, microwave ablation is fast. It can be done by USG guided and laparoscopy guided. So yes, microwave ablation for uterine diseases, no conflicts of interest. I think the basics of microwave already Dr. Gong has completed. Basically, to tell you in short, microwave is an electromagnetic radiation, and it has a particular way it interacts with any tissue that contains water molecules. It quickly ionizes a bipolar water molecule, which start rotating at a very fast rate and which causes friction and causes increase in temperature and tissue necrosis. This is the equipment which I use. This is the microwave generator, and you have the antenna, which is 15 gauge, up almost 3 millimeters, just less than 3 millimeters, and it is about 20 centimeters long. And yeah, so the microwave ablation, the current technology has evolved to give you an almost spherical ablation zone. So you can study your case, know the exact volume of your lesion, whether it is fibroid or adenomyosis. And depending on that, the company will give you the chart that at what setting you will get what size and volume of ablation. Okay, just I'm showing you this video to tell you how powerful and precise energy tool microwave is. This is the egg white, which is being ablated, and you can quickly see the coagulation necrosis that is happening there. And it is like you normally take 2 minutes to boil egg. This is in seconds. So you have to beware, as Dr. Gong said, microwave is a very powerful tool whenever you use it. So my principle is to under ablate. Don't go for full ablation, be less than 70% of the lesion. Okay. Yeah, so we did our first case, which was on 15 June 2021. And this is one of the first cases. She was a 37-year-old female. She had menorrhagia, single solitary fibroid, about 6 centimeters, and she strongly desired for a non-surgical treatment. So we thought that maybe this is the ideal case for microwave ablation. So this is one of the first cases of microwave ablation for myoma that we performed using the Lumba approach. This is a posterior wall, Figo type 5 to 6 fibroid, and as you can see, the antenna has entered through the abdominal wall, and now the antenna enters at a particular point that we have predetermined through the myoma, through the serosa and through the capsule of the myoma into the substance. Now, before we apply the protocol, we start the chilled saline continuous circulation through this antenna, which keeps the temperature of the antenna below 20 degrees Celsius, and only the tip of the antenna, near the tip of the antenna, say about 11 millimeters from the tip, there is an aperture through which microwave is released. And as the microwave is applied, you can see in the sonography picture that echogenic bubbles start appearing, and you can see the ablation zone being created. So you have to constantly monitor by ultrasonography the extent of ablation by monitoring the ablation zone by visualizing the echoes that are being generated by microwave. So for this particular myoma, which is about 5 to 6 centimeter of size, we have predetermined that we would use short protocols with overlapping ablation zones. So I have already ablated one zone. Now I have removed the antenna from one point and I am piercing it into another point to create another ablation zone. And again, as I activate the protocol in the generator, the echogenic bubbles start appearing and another ablation zone is created, and this ablation zone is going to overlap with the previous ablation zone, so that nearly 80 to 90% of this fibroid is ablated. Over the course of next 8 to 12 months, this myoma is going to shrink in size about 80 to 85%. And in the end, we determine that the entire myoma has been ablated by using color Doppler. So another method of determining whether the ablation has been done is using contrast enhanced sonography. As you can see, the cavitational effect where the contrast does not reach is the ablated zone. And this was the post-operative picture at 9 months. We had about 66% of volume reduction and the patient became asymptomatic. So and here's another case of laparoscopy and USG guided microwave ablation for adenomyosis. I think for adenomyosis, this is a very good technique because the surgery itself is a very difficult surgery, and we always have our questions and doubts regarding the outcome of adenomyomectomy, whether it is laparoscopic or open. So again, I generally use laparoscopy always because, as mentioned by Dr. Gong, there is always a risk of thermal injury to bowel or bladder. And I think doing a low pressure laparoscopy can easily prevent that. We have had no thermal injuries to any major organs. What we do is we antivert the uterus. So this is setting of the protocol on the generator. So that is set at 40 watts. And then with the acute antiversion of the uterus, we can easily see both the walls of the myometrium on the ultrasound. And initially, under laparoscopy guidance, the needle is inserted in one wall. So this patient had about 73 ml of volume of adenomyosis, including both anterior and posterior walls. So we decided to use ablation on both the walls using the moving shot technique of ablation. And the uterine cavity is determined by the continuous saline irrigation that is happening through the manipulator. So that is the ablation zone in the posterior wall. Laparoscopy also gives you an advantage of, many a times adenomyosis will be associated with endometriosis and other ovarian lesions. So you can treat that as well. The radiologists who are doing ablation cannot do laparoscopy, so they don't have that choice, I guess. Similarly, the needle is inserted in the anterior uterine wall to take care of so that is the uterine cavity. The Yeah. In the center, you can see the uterine cavity. With the continuous irrigation, it gives a good contrast. So you can know, and that is the microwave needle entering. And we ablate at a point, we see the echoes, and we don't have to reach till the echoes should not reach to the endometrium, should not reach to the serosa, and then you move your needle. That is known as a moving shot technique. And the damage to serosa is very, very minimal as compared to laparoscopic adenomyomectomy. So I think this, and plus this can be combined later on by inserting Mirena. So using all these conservative techniques, probably we can save the uteruses in a better way, and probably we can utilize these techniques in the patients who have age less than 40 years, so that at least we can postpone, if not at all, completely avoid hysterectomy. And yeah, so thank you so much. And I invite you to AAGL, which is an upcoming, one of the biggest endoscopy event, the 18th International AAGL, which will be in Mumbai from 1st to 4th June. If you have any questions, please post it on the in the chat. We'll quickly try to answer them. I will hand it over to Dr. Soumil and Dr. Sanket sir to take over and carry out the discussion and Q&A session. Thank you so much.
Thank you, Suyash, and thank you, Dr. Xiaoming. I think that was really an eye-opener. There are many concepts which I had read only in books, but to see them firsthand and to see actual videos of surgeries being performed is really an eye-opener. And now we have an alternate perspective that we did not know existed, or we did not know its true potential. So Suyash, if I may start with you, when you talk of ablation for a fibroid that is, let's say, 5 centimeters in the posterior wall, how do you see this technology in the future standing up against the already existing gold standard of a laparoscopic myomectomy, since you're already halfway there with the telescope and the pneumoperitoneum inside? And even for maybe not someone as skilled as you, but a little lesser skilled, would still be able to perform a laparoscopic myomectomy. So how exactly do you pitch this technology to the masses in terms of an already existing gold standard?
I think Dr. Gong should also answer this, but I will try to answer in my way. See, it is not a replacement to myomectomy or any other techniques or medical management in any way. It is another tool in the box. Okay. And we should know as many alternatives as possible, because some patient might have some coagulation disorder. She may be unfit for some other reasons, and she might require some kind of a more aggressive treatment compared to the medical management. And
Right.
as of today, we do not have the evidence or for the fertility usage of ablation for fibroids or adenomyosis. But maybe tomorrow, as this technique grows and with more evidence, we might be able to use this for fertility preservation. And if these females who have future obstetric prospects, we cause minimum scarring of the myometrium, probably she may have a better outcome. Of course, if we use ablation in a safe manner without damaging.
Understood. One more question, please. How is this at present only recommended or generally used for FIGO type 4, type 5, or as the fibroid gets intramural and becomes closer to the endometrial cavity, can one still use this, or are there any guidelines as such to screen out those patients and not include them at present?
I think I personally have not used it for type 1, type 2, or type 3 myomas. I think for this question, probably Dr. Gong is better qualified to answer.
Okay. In China, we have some doctors from the intervention radiologist. They do the ablation therapy, even for the type 0 myoma. So I think that's because they don't do endoscopic surgery. So for me, I want to do that. I would do I will prefer to do the hysteroscopic surgery for the type 0, type 1, type 2 myoma. If the myoma is greater than 5 centimeter, usually it is harder to do the hysteroscopic surgery. Sometimes I will do ablation therapy and wait. One case, I will show you one case. She is very interesting. She is about a 10 centimeter myoma, type 2 to type 5. And we do the microwave ablation therapy first, percutaneously. And we also put a marina for her because she don't want to have a fertility requirement in the next 5 years. So we wait and see. But interestingly, this myoma turns to be a type 0 after 2 months. So that's a very interesting. This myoma in the first time, she is type 2 to type 5. And then after ablation therapy, they become to be type 0. So after the myoma penetrate into the uterine cavity, we do the endoscopic surgery, we remove it. So usually, I do endoscopic surgery well, so I will do hysteroscopic combined with microwave ablation therapy at the same time. That's a very unique thing in the world. I think many, because in China, when the radiologists do, they don't use endoscopic surgery. I will do. So that's my opinion.
Okay, thank you. Thank you. That answers. Thank you.
So Dr. Gong, you mentioned about the PBT system, which you use for the transcervical approach. Now, there is also the Sonata system of radiofrequency ablation, which has a, is it available in China or it's?
No, I know Sonata system in US. It's similar to microwave. It can in China we have a similar radiofrequency system like Sonata. When I work, because I didn't use the Sonata in the past time, when I watch the videos, they do the laparoscopic assisted monitor. But I think that if I do the percutaneous, like the fibroids, I prefer to do the with the ultrasound guide because it was less trauma.
So this was mainly for, like maybe type 2, type 3 fibroids or something, wherein because the Sonata has an intrauterine ultrasound probe which goes inside the uterus, and then the needles come out. So that was my one question. And about the transcervical approach, any risk of endometrial damage, how do you prevent endometrial damage if you're using the transcervical approach?
I think that in the early years, like the 7 or 8 years ago, I do one case for the radiofrequency ablation therapy, but she had endometrial damage. So after that, we stopped using radiofrequency for the fertility patients because the difference with radiofrequency probe and the microwave antenna is microwave, they have a circulating system. So the tip of the needle is very hot, but the body of the needle is cold. But the radiofrequency, because the probe will penetrate inside the from the from the uterine cavity, it will also has energy along the probe, so it will cause the endometrial damage. So we don't use radiofrequency for the fertility patient.
Any role of yes.
The radio frequency is actually an older technology.
Of course.
And you also require a return plate for that. And therefore it can cause skin burns. That is one thing. Second is it is weaker in terms of ablation power compared to microwave, because it has, it can ablate up to few millimeters directly, and after that it is mainly by conduction of heat that it causes necrosis. So it is recommended to use radio frequency for fibroids less than 4 or 3 centimeters. So it has a very limited role, I guess.
There's one question, because in the videos which you showed, you always used a combined approach of laparoscopy and sonography. So sonography was basically just to determine the zone of ablation, right? Or is it mandatory, or can you just do only laparoscopy without sonographic guidance?
I think sonography is mandatory. You can do without laparoscopy, because how the needle is entering, where it is entering, which part of lesion it is entering, how far it is from the margin of your lesion is more important to determine. The purpose of using laparoscopy, and that too, it is a, I keep laparoscopy pressure at 5 or 6. The only purpose of laparoscopy is to move bowels away. And the way to do it by ultrasonography is by causing an artificial ascites. I think Dr. Gong might also be using that technique. They cause an artificial ascites by instilling more than 1 liter of saline to move away the bowel. Plus water gives a good contrast, normal saline. Dr. Gong, what do you have to say about that?
Yeah, in the beginning we use ultrasound as well, but later on we quit ultrasound because usually when we puncture from the abdominal wall, the angle of the needle usually is very hard to detect when you do the vaginal ultrasound guide. So we did a few cases with ultrasound combined with laparoscopic surgery, but later on we quit ultrasound. So if we want to do the ultrasound, sometimes we do the transvaginal ultrasound combined with a transvaginal probe. So we will puncture from the cervix.
But then how do you determine where the needle position, the antenna position is?
Yeah,
without ultrasound?
You can, yeah, you have it's have a tunnel. So when you puncture along the tunnel, you can see the needle very clearly. We did a lot of things. I think that you can find some. We do a lot of this ovarian cyst sclerotherapy. So you can see very clearly with the vaginal probe.
Suyash, also the probe which you were using and Dr. Gong was using, was it the same or different? Does it have any centimeter markings or something on it to guide you as to how much you have penetrated into the fibroid? Does it have markings?
Yes.
Yeah, it does
I
have.
saw in the video of Dr. Gong, in the second video of yours, I didn't see the markings, I think. So
yes, you can detect you can detect the length of the needle, how deep you penetrate. But usually you just detect, you want to see where is the boundary of the myoma. So that's all. So in the beginning, I think in the 7 years ago, we started to do the abdominal ultrasound guide. We are not experienced with the ultrasound, so we have to measure, because the hardest thing for us is to try to find the needle. Where is the tip of the needle? If you miss it, you start to ablate. Sometimes it will cause damage to your bowel or to your bladder. So in the beginning, we will try to check make sure where is the tip of the needle. But later on, because we're quite experienced with ultrasound, so we don't use that one anymore.
Dr.
There is
Gong,
a learning curve and a skill involved in holding the ultrasonography probe in one hand and then pointing the needle and visualizing it in ultrasound. So one has to undergo that.
So one more question I have for Dr. Gong. I think you mentioned this ablative therapy is being used for cancers. at other sites like kidney and the lung and everything. Now, do you feel it has any promise in any gynec cancer or something, or that is an absolute contraindication?
I think that for our gynecology cancer, it's resectable. In most cases, it's resectable. Yeah, but for the lung cancer, they do the treatment with ablation therapy with the early stage of the lung cancer, because when they do the ablation therapy, they will not only cover the tumor, but they will also cover the out layer of the tumor. I mean that we have to cover all the area of the tumor. But for us, like the uterine fibroids and the adenomyosis, the most important thing for us is safety. So I think that if you have endometrial cancer, if the patient is not resectable, she's not unable to do surgery, so probably we can choose to do ablation therapy.
And because it's a concerning topic, any undetected leiomyosarcoma accidentally have undergone microwave therapy or something? How do you, so what's your criteria, or how do you, like your sonographic patterns wherein you decide that this case is suitable for microwave? So what is the exclusion criteria based on MRI or sonography wherein you will never attempt a microwave ablation? Because despite the best imaging, sometimes it's undiagnosed. So what tips or advice would you like to give for that?
I think the first thing is that the fertility problem. As I see, if the lesion is too small, you have the possibility to damage the endometrium and the myometrium. So I think that for us, the first thing for the fertility patient is that to keep the ablation, the boundary of the ablation therapy. If they go beyond the lesion, it will cause damage. The other thing is the T2 signal. You know, the MRI image, when you see the T2 signal is very high, that means that, in other words, it has many watery ingredients inside the tumor. So it's just like we have to burn the tissue. If you have too many water, it's not too easy to burn it. So for the patient, she has a T2 signal myoma. We prefer to do a mammectomy or hysterectomy. If the patient want to persist, she want to do ablation therapy, right now we will try to use the Gynecology for several months. And after several months, we will prefer to do the ablation therapy, especially microwave, because we started with HIFU and focused ultrasound. It's very interesting. One case in the past, we have one case. She want to do focused ultrasound in the beginning, and after we try for 1 hour, it's very resistant to the energy. So we have turned to the microwave. So in her cases, I will let you know that microwave is a very efficient tool for us to do ablation therapy. So right now, I think the most of the cases we will choose microwave.
Suyash, you want to add to this anything regarding undiagnosed leiomyosarcoma or something like that?
Yeah. So, Soumil, there are many centers, I think, which are advising a true cut biopsy. And after histopathology, they take the patient for ablation. Okay, that is one way of looking at it. And second is, as Dr. Gong said, that you can, have a very unusual looking fibroids, you can, simply go for more surgical treatments.
So a degenerated fibroid or something would not be very suitable for a...
No. You go for a very routine looking, yeah.
I will show you one of the slide. I just didn't show that because this one, let me see how to
you can share your screen again.
Yeah, let me see, where is the share. Yeah, here it is. So this is our tool for biopsy. So right now, so can you see it?
Yes.
Yeah. Yeah. So right now, with the patient with myoma, if the patient she didn't have the biopsy or have the pathology before, we will do the biopsy for myoma patient, for every myoma patient. For adenomyosis, we do biopsy.
You do biopsy for adenomyosis, or you don't? Sorry, I didn't hear you.
Well, I don't do for adenomyosis patient. I will do for the myoma patients.
So, Suyash, I think what you showed was more like a diffuse adenomyosis because you injected anteriorly as well as posteriorly.
Yeah.
So obviously, I think focal will obviously respond much better.
Yeah, definitely. Focal is an ideal case scenario. And I think my more than fibroids, I am much more convinced for adenomyosis as of today. But as you know, as various rules and regulations come in, and as the approach of and desirability factor of patients change, probably it will have a role even in India for fibroids. Who knows?
And Suyash, you mentioned saline and irrigation through the manipulator to just outline the cavity and continuous saline. So continuous saline, how do you
I use a Histromat.
Histromat.
Yeah, and that is continuously pumping fluid through the uterine manipulator, the one which we use for chromoperturbation. So I see two advantages. One is that it delineates the cavity very well, and secondly, if at all by mistake we are close to the endometrium, it might dissipate some heat. So that is not how you should look at it. You should try to be away from endometrium unless you are looking for ablating endometrium.
Okay, when would any one of you can take this? When would you call it as a failure of microwave ablation, or do you ponder over a second sitting for ablation after the first microwave ablation, or what would you call as a failure of microwave ablation, or it will definitely shrink? Is my question.
I think there is one study which has made that classification of desirable ablation or under ablation, and I think what they suggest is that if you have ablated less than 20 or 30%, then that is definitely a failure. So failure in terms of ablation, that you have ablated less, is a different thing, and when you have ablated and there is a recurrence of the lesion, that is a different thing. Dr. Gong?
I think the definition of recurrence is very hard, because when I read the literature, they said the after ablation therapy, the recurrence is low. Because I read the literature regarding the HIFU, but I don't agree with this one. I don't use the recurrence rate, because if you want to use the recurrence rate, usually patient with the ultrasound, the examination after the treatment, everybody will find the myoma after the treatment, even after 1 year or 3 months or 6 months. You can see the myoma is still there. It's just the shrinking size. So I don't like to use the recurrence rate. Usually I would tell my patient that if you want to use the recurrence rate, it's 100% recurrence. So we don't like to use this word when we do the ablation therapy. It's totally different with the resection therapy. If you do laparoscopic surgery, you don't see the myoma, and you see it again, it's called a recurrence. But after ablation, we prefer to use the reintervention rate.
So how much is that, Dr. Gong? We can take this as a last question, that the myoma has shrunk to say 80% when you have done an MRI after 12 months. And what are the chances of this regrowing in the next year?
In my experience, because we will re-intervene with the patient, like with myoma, if she still have like heavy bleeding, we will do another ablation therapy. I mean, endometrial ablation therapy for her, or sometimes we put a Mirena for her afterwards, and sometimes we do the myomectomy or hysterectomy. So the total reintervention rate for us in 2 years is about 15%. 15% is not too high, but later on, after because that's the statistic in the first several years. But in the recent years, this rate decrease is about 10%, less than 10%, because right now we do for the patient with a very myoma and she had a heavy bleeding, we will do ablation therapy for the myoma and ablation therapy for endometrium as well. And we also will put a Mirena for her. So we'll decrease the rate of her reintervention rate. So that's our method.
One last question, Dr. Gong. After that, Soumil, if you have, you can ask also one more last question, and then we will conclude.
Sure.
You said about inserting Mirena sometimes in fibroid, in myomas after ablating, and sometimes in adenomyosis after ablating. One is, how do you choose which patient you want to put Mirena, and when do you put? After how many days or months after ablation, or immediately after ablation?
Right now, I think that if the patient she don't have the fertility requirement in the future, in most of the cases we will try to ask the patient to put the Mirena in the meantime. In the meantime, when we do the ablation therapy.
When will you put Mirena after ablation? How many days later?
Right after the surgery.
Right
during
after
the
surgery.
surgery.
Okay.
During the surgery.
Because after the surgery, there is some degree of vaginal bleeding and discharge that can happen. So doesn't matter. Okay.
Yeah.
So coming to the same question, I just wanted clarity again. So Dr. Gong, you said reintervention rate has dropped to 10%, but reintervention is never a repeat myoma ablation. It's not a repeat. It's not a second sitting of a myoma ablation, or that is also done. And when do you do it? When will you contemplate to do it if that is an option?
Yeah, usually, I mean that if the ablation therapy is done 5 years ago, the patient would like to choose a second ablation therapy. We had several cases. Usually, it would be the first case we do with a focused ultrasound, and the second one we will do the microwave. That's usually we had several cases. But if the patient she had a failure, what we call the symptom is not relieved well, usually we will ask her to do hysterectomy. If she doesn't accept the hysterectomy, we will prefer to do a laparoscopic lesion resection or vaginal one.
Okay. Thank you so much. I think we will have to end the Q&A session, although it can go on and on. I'm sure we'll have more sessions, and maybe in future we'll invite Dr. Gong to India, and yeah, surely we can continue discussing after that. So I think what I understand from microablation is that it is one of the techniques. It is one more tool in the box. And as Dr. Gong had mentioned in his slide that we have to be master of 18 weapons, we should try to become that. And I think the requirement of such a therapy stems from the strong desire from the patient to avoid hysterectomy. And also, if like in India, what is happening currently is that authorities are looking at this very seriously to reduce the rate of hysterectomy. So I hope that everyone who has attended the webinar might have gained a lot of new information and new insight about this topic. And I thank entire AMOGS team, Dr. Rajendrasingh, Pardeshi sir, Dr. Sujata Dalvi madam, Dr. Sunita Tandulwadkar madam for taking out time. And I sincerely thank Dr. Gong for taking out time from his busy schedule for this webinar and to enlighten us about this topic. Thank you, Dr. Soumil, Dr. Sanket for a great discussion and for great question to make it more interactive. And thank you, Intas Pharma, for sponsoring this and for giving us a platform. And thank you, everyone who has attended, and see you in the next webinar. Thank you.
Thank you. Thank you,
Thank you.
Suyash, Dr. Gong. Thank you.
Thank you for inviting me. Thank you. Bye-bye.
Bye-bye. Okay, we can end the webinar. Support team.
Sure, sir.